So let me start with my presentation. I'm going to talk about the management of endometriosis at the extremes of reproductive years. So let me start by the definition of reproductive years. What is the definition of reproductive years? According to WHO, it is the range of ages during a woman may become pregnant. So in other words, it's the ages between 15 to 49. And when we talk about
we can't see the screen.
Yeah. Okay.
Sorry.
When we talk about the extremes of reproductive ages, then we must cover adolescent group, which is between 10 to 19. And the other end is menopausal transition, which is 45 to 55. Let me start with the management of adolescent endometriosis. Then what is our aim to manage a girl with endometriosis? First, definitely symptom relief. And the other thing is suppression of disease progression. As we know, endometriosis is a progressive disease. There has been lots of debate on this, but at this stage, we know that especially at the adolescent age group, it is a progressive disease. So we have to care about its suppression. And the third thing we should concern is the future fertility. So we have to care about her future fertility. I said pain. Pain is the most prominent symptom among this age group. And there has been many kinds of pain during this period when we compare with adults. It can be chronic pelvic pain and it can be dysmenorrhea, or it can accompany GI symptoms or urinary tract symptoms. Interestingly, it has been reported that there is higher prevalence of migraines among this age group with endometriosis. One study showed us that 3 out of 4 girls has laparoscopically prone endometriosis when she has chronic pelvic pain resistant to medical therapy. So if there's a girl with chronic pelvic pain resistant to medical therapy, then approximately 75% of those girls do have endometriosis. We all know that there is no cure for endometriosis, but we have to care about its progress and we have to care about future fertility and also pain. So all adolescent girls with endometriosis should be managed with long-term treatment. What are the management options in adolescent group? It can be medical, surgical, or we have to care about fertility preservation. And there are other optional therapies or alternative therapies. Unfortunately, there is no solid data on them. Let's start with medical treatment. Unfortunately, among
Excuse me, ma'am, can you show the slides? Can you?
We can't see the slides.
Oops, you can't see the slides?
We cannot see the slides. Can you show? No, okay. No, we cannot see.
Okay. I'm sorry. Is it okay now?
Yes, we can see now. Right now we can see.
Oh, good.
Yes, thank you, yes.
I'm sorry.
Okay, then.
Okay. All right. Let me go through this. And okay. Let me start from the aim again. The first, symptom relief and suppression of disease progression, and we have to care about future fertility. As I said, there are more varied pain when we compare with adults. So medical management, let me start from here. Unfortunately, there is no high quality literature or papers on among this age group. So high quality evidence is still lacking for this age group. We know that most medical treatment modalities are extrapolated from adult data. We should bear this in mind. Medical treatments can be non-hormonal or hormonal. When we say non-hormonal, the primary drug we may choose is non-steroid anti-inflammatory drugs. There are many of them, but there is no superiority of those one over the other. So they're almost the same. Are they effective? Not established in adolescence. And however, it is recommended as an additional treatment option, especially lastly, ASHA guideline has been released in February this year, 2022, and it is also said that it is recommended as an additional treatment. So we give non-steroidal anti-inflammatory drugs plus hormonal therapy to these girls. How about the opioids? Opioids are not appropriate for the treatment of adolescents with dysmenorrhea because of the risk of physical dependence and addiction. So we don't use opioids among this age group. Cabergoline is sort of a new horizon, I would say. It inactivates VEGF2, which is an important element of angiogenesis. It can be given twice a week, 0.5 milligrams. And I think we will have more data in future with cabergoline. It has been shown that it decreases the size of the endometrioma, and it is effective as medroxyprogesterone acetate and even better tolerated. So I do hope in future we'll have more literature on this, and it's safe medicine. Combined oral contraceptives, we accept this as first-line therapy option. Monophasics are preferred and continuous use is preferred. So if we give combined oral contraceptives to these girls, we should tell them continue, do not give any break at all. And how does it work? These medicines suppress ovarian estradiol production, hence decreases endometriotic proliferation and growth. Also, it induces atrophy and or decidualization. There's one paper saying that if there is a risk of endometriosis, if we give the medicine and stop it, according to the findings, although there are some methodological problems with this study, it has been shown that past users and ever users, there's a trend to risk of endometriosis. However, when we look at current users, there is especially very high decrease in the risk of endometriosis among these girls. Until when we should continue combined oral contraceptives? It is recommended to use until the fertility desire. So we tell those girls, continue medicine until you want to have a baby. Progestins are important, and they are also first-line therapy. There are many kinds of progestin options. They basically create progestin-dominant environment and leading to decidualization and atrophy of the endometrial tissue. Again, it's first-line therapy. But we have to be careful about it because some of them may decrease bone mineral density, especially DMPA. First option would be norethistérone or its acetate. It is effective and well tolerated by most adolescent girls. It can be given 5 to 15 milligrams daily. How about DMPA? We should avoid prescribing DMPA because it decreases bone mineral density in adolescent group. There's another medicine that we can give. I don't know whether you have it there. It's Dynogest. There's a big study. It's called Vision study to assess the safety in adolescent girls. And the secondary aim of the study was to see the pain decrease. And 2 milligrams per day orally created a major decrease in the mean pain score. It's from 64 to 9, so it's a great decrease in pain. However, we should be very careful because it also decreases somewhat bone mineral density in adolescents. All those studies suggest that when we stop giving the medicine, then there is a partial recovery, but we have to be careful about it. There is another progestin, it's dydrogesterone. It's sort of a rising star indeed. Recently, there are many publications in different kinds of treatment modalities, not only in endometriosis. For endometriosis, there is one study covering 350 women with endometriosis and chronic pelvic pain, not specifically on adolescent group, but includes adolescents as well. And it has been shown that it is effective in terms of decreasing pain. GnRH analogs, strong drugs. There are some rules that we have to obey if we want to prescribe GnRH analog. First, it should be proven endometriosis. In other words, laparoscopically, we have to see endometriosis is there. And second rule is there should be no or suboptimal response to routine hormonal treatment, such as combined oral contraceptives or progestins. And third rule is age. Age should be above 16. So if it is so, then we can prescribe GnRH analog, but we have to bear in mind that it decreases bone mineral density deeply. So we have to give add-back therapy. We can give estrogens plus progestins or progestins only. Both is okay. When to start add-back therapy? Immediately. When we start GnRH analog, then we start add-back therapy as well. And it can be given monthly or 3 monthly injections, but we have to be careful that there is flare effect may occur. And this means that some days later, pain may increase. We have to warn the girl with the flare effect, for the flare effect. And how about the BMD measurements? Should we measure BMD before the treatment, before prescribing GnRH analog? According to the literature, no, there is no need to check bone mineral density at the initiation of the therapy. However, we should check after a year and then every 2 years. GnRH antagonists, promising data we know for adult women, but we don't have enough data for adolescent group. Surgical treatment, among this age group, we have to be very careful when we offer surgical therapy. And it is not the first-line treatment option for these girls. If there is no response to medical treatment, then we can consider laparoscopic surgical treatment of endometriosis among adolescents. However, it's not the first-line therapy. The aim of the surgical treatment among this age group is definitely, again, to destroy or remove endometriotic lesions. However, there is no data supporting radical excisional surgery. In other words, no peritoneal stripping in adolescents. We have to be careful about it. And after surgery, should we give any medicine? The answer is yes. If we somehow do the surgical treatment, then we should definitely give medical treatment afterwards to prevent recurrence. So long-term post-operative treatment is definitely needed to prevent recurrence. It can be either estrogen plus progestin or P only, progestin only, but it has been shown that if we give estrogen plus progestin, it is superior than progestins only. What are the risks of surgical treatment? Because we want to a little bit avoid among this age group, avoid surgery among this age group. The first risk is ovarian reserve decrease in ovarian reserve. And the second risk is sort of hypothetical risk. It can be surgically induced endometriosis. In other words, we may spread endometriotic cells. And third thing we have to consider is the earlier the surgery, the higher the risk of recurrence. So if we offer surgical treatment, we should think about it twice, because it's gonna be only one, hopefully, surgery. So we have to be careful with timing of the surgery, if she needs or not. I told about recurrence. How about the recurrence among adolescents? According to the literature, if the years pass, then we can see higher recurrence rates. In other words, let's say for 5 years after the surgery, there is 20%, approximately 20% of recurrence rates among adolescents. So we have to think twice when we offer surgery to those girls. Fertility preservation is another important issue. We have to discuss it with her and with her family. It can be done either ovarian tissue preservation or oocyte preservation, especially for the girls with bilateral endometrioma or who is going to have ovarian surgery. So especially for those girls, we have to consider fertility preservation in one way or another. Let's come to the other end, to extremes of reproductive years. It's the perimenopausal period. Is it common, or how common is it? According to a big data, it has been stated that 1 in 7 of cases with endometriosis are around these ages, so perimenopausal period. What is the aim of our management among this age group, perimenopausal group? First, definitely symptom relief. Symptoms can be related to endometriosis, or there still can be fertility demand among perimenopausal women. or there may be some symptoms related to menopausal transition. And there are other issues that we have to think about. One of them is associated clinical scenarios based on hyperestrogenic state of the woman. And also we have to think about the malignancy issue among this age group. Symptoms related to endometriosis, mainly pain and fertility demand. These are the big issues. Perhaps in another meeting we can discuss about it. I'm going to cover symptoms related to menopausal transition at the moment, and also I'm going to talk about the problem in differential diagnosis among this age group. Menopausal symptoms. When we talk about menopausal symptoms, one question would be, is menopause earlier in women with endometriosis? And the answer is yes. Doesn't matter if she had surgery or not, it has been shown that the menopause age is earlier than in women without endometriosis. So we have to consider these women with earlier menopause. Should we give hormonal therapy or should we avoid giving hormonal therapy, menopausal therapy? It has been stated that women should not be denied the replacement solely due to endometriosis. Hormonal therapy and endometriosis, what to give? There are some rules again. First one, we should avoid estrogen-only regimens, and also combined therapy. In other words, estrogen and progestin is appropriate therapy. So we should give combined therapy. We should avoid estrogen-only regimens, and possibly we should give in a continuous fashion. If symptoms related to the recurrence of endometriosis, in other words, pain is there or pain is started once again, then we have to cease hormonal treatment and we have to check the lady once again because of the fear of malignancy. There are associated clinical scenarios, as I mentioned earlier, stemmed from hyperestrogenic state. They also can cause pain, subfertility, and bleeding. In one of our paper by Engin and I, we named this as we show here, it is the triangle. It is the triangle. Sorry. That's what we call dragon's triangle. And as I mentioned, endometriosis and malignancy is another important and big issue. We know that there is not much cases with endometriosis and malignancy. However, there is a proven association with malignancy. So we have to be careful about the malignancy issue as well. Positive association between endometrioma and ovarian cancer has been shown. Especially these data came from Japan, and it has been shown that if she is above 40, we have to consider malignancy. And also from Engin group from Turkey, it has been shown that endometrioma-associated ovarian tumors were found in 11% of cases with endometrioma. So if there's a lady around or above 40, we have to differentiate it, differentiate whether it is malignant or benign. Unfortunately, there is no definitive marker So if we come across a lady with endometriosis or endometrioma in this age group, we have to, we can go through this flow chart. So we have to check if there is suspicion of malignancy. We can check it with transvaginal ultrasound. We can use IOTA criteria, and also we can use MRI findings. We know that blood measurements or serum biomarkers cannot work well, except Roma index. If there is suspicion of malignancy, then surgery is a definitive way to follow. If there is no suspicion of malignancy, then we have to check whether the lady desires fertility or not. If yes, we should go for an IVF cycle. If no, if there is, we have to check for pain. If there is pain, then the first line treatment among this age group, if there is no fertility desire, is definitely surgery. If there is no pain, there is no fertility desire, and if we found, let's say, endometrioma by chance during the ultrasonographic examination, then we have to discuss it with the patient. According to the literature, there is nothing we can definitely say. However, we may suggest surgery to a lady because of the risk of malignancy in future. So, in conclusion of my talk, in adolescent endometriosis, we have to treat adolescents until fertility desire, and medical therapy is preferred option. And if surgery is definitely needed, and if surgically treated, and afterwards we should definitely give long-term medical therapy. And among perimenopausal women, we have to consider surgery first. And if the lady needs menopausal hormonal treatment, for example, due to hot flushes or something like this, then we can prescribe hormonal therapy, but combined formulation should be chosen. In other words, no estrogen-only treatment. And also, we have to be care about the malignancy issue. Actually, that's all I can tell you at the moment, and I'm very much honored to be with you tonight. I don't know whether you have any questions or any comments. Thank you very much.
Thanks a lot, ma'am, for giving your precious time and busy time. And it was a very great presentation. And I'm very happy to see you. And it was the first presentation from Turkish doctors for Afghan doctors. And many thanks from you.
I feel myself privileged. Thank you very much. It's my honor, really. And if you wish, we as Turkish Endometriosis and Adenomyosis Society, we may give some more talks if you need it, or we can communicate. It's our great pleasure to do so. Okay?
Yes. Why not? Why not, ma'am? Yes. We are very. Yes. Thank you. Thanks a lot.
Thank you.
If there's any question from doctors, they can ask from you.
Thank you so much, Madam, for your nice presentation. It was very useful. Madam, here in Afghanistan also we have so many endometriosis cases, but we cannot diagnose it. Just by ultrasound and by a clinical feature, we guess that it must be or might be endometriosis. So we want to collect data. So we want to choose the variables by your help. Which kind of variables we should choose that we can collect good data to have some correct data in Afghanistan for endometriosis.
So if I understand correctly, what are the things to diagnose it? Is that right?
Yes.
No. We want to have research on endometriosis, but how much data do we have in Afghanistan? Just we want to have the variables, which kind of variables we can choose in order to have good data.
Okay. For publication purposes, I would say more than 100 patients would be okay. And you have to look for not only clinical diagnosis, but also if you want to publish it somewhere, definitely you need laparoscopically proven endometriosis. This should be. However, if there is endometrioma on the ultrasound, you may also use such cases. One warning, according to Las Esche, we don't have to do laparoscopy among adolescent group to do a diagnosis. So we can just use pain and or ultrasonographic picture. Is that your answer? Is it okay for you? Is that the answer is okay?
Yes. Anyhow, we are not able to do laparoscopies in Afghanistan. Just we have ultrasound facilities, and also according a clinical feature, we can guess that, and mostly in infertility cases, we do see that there are some cysts in the ovaries, and there are some hepatization inside the cyst. So we guess that this patient with dysmenorrhea or dyspareunia might have endometriosis. So we want to choose the data that without laparoscopy, we reach a good diagnosis, and we could have some good data for Afghanistan.
Right, it's okay. I mean, if you see the endometrioma is there with a ground grass appearance, it is typical for endometrioma, and you may also see a mural nodule, but we have to check. There is no vascularization. High vascularization means that there may be a malignant situation there. So if you do so, then it is also fine. But apart from endometrioma, it's very difficult to assume that pain is the only way to diagnose, or you may not see peritoneal endometriosis by ultrasound anyway. So if you think about there is pain, and with the vaginal examination, definitely there are some clues. There will be some clues. We check for it. For example, Douglas obliteration is one of them, and rectovaginal nodules, maybe painful nodules, maybe. But if you want to do a publication, definitely these won't be enough. So, yeah. And for bladder endometriosis, definitely you need a cystoscopy as well. So apart from endometrioma, it's very difficult to perform a clinical study indeed.
Thank you so much. In the treatment of endometriosis, you told that cabergoline may be given for the patient. Would you please tell us about the doses and duration of this medication?
All right. It's a new approach, really. And there is one big study started from Boston group. It's not well-established treatment modality for endometriosis anyway, but it is said that 0.5 milligrams twice weekly, in other words, let's say Monday and Thursday, you can give one tablet, and the duration is unclear because we don't have any solid data, but it is a very promising medicine that hopefully in future we'll see it more, we'll hear it more.
Thank you so much. It was very useful. Thank you so much for your precious time. Hope we could have more of your nice presentations regarding infertility as well.
Hopefully, yeah. We'll be pleased. We'll be honored to be with you again and again. And hopefully we can see you here in Turkey, perhaps. It'll be very nice to see you around like Layla. Layla was here in Turkey, and hopefully we can meet face to face.
Yeah, thank you, ma'am.
So
inshallah, inshallah, we will come there.
Inshallah.
And we are waiting for your great presentations. Thanks a lot for giving us your great time. Your busy time, great time. Thanks a lot, ma'am.
Thank you. Bye-bye. Bye.
Have a good night. Have a good night.
Stay healthy. Bye-bye.
Thank you. Bye. Bye.
Bye-bye.
Bye.
Thank you so much.